Hello, good afternoon. It is that time again. It's 4 o'clock in the mountains, which means 6 o'clock on the East Coast and three in the West. And it's time for Fertility with Fink and Friends. I am Fink. You are Friends. My name is Dr. Randy Fink, and I am the clinical director of IVF services here at CNY Fertility in Colorado. Beautiful Colorado Springs. We have offices, gosh, all about the country, sort of. When I say all about, I mean, well, at least in a couple of places. We're in Syracuse and Buffalo and Albany. We've got a monitoring center in Rochester. We have a full service office in Sarasota, and here in Colorado Springs, we have a monitoring center in Norfolk and in Atlanta. And I think I got them all, but it is so nice to see all my friends here. Happy Tuesday. I hope everybody got to enjoy a wonderful 3-day weekend. Memorial Day is, I think, is a very special day, and if you saw my Instagram post from yesterday, I am particularly thankful for those who we still have, and that would be I put a nice picture of Grandpa. That's Captain Harold Fink, former U.S. Army retired aviator, living in Mobile, Alabama, and I do believe my wonderful mom and dad are probably watching on the YouTube side here. So a special hello and thank you to you. Veterans Day is an important day. We went to the cemetery and put some flags out for those that we have whom we have lost, and I just think we all have a lot to be thankful for, to be able to live the free lives that we live, to thank all those who have sacrificed in our armed services so that we can live a life that's free. And our thoughts go out to all those families with a missing spot at the table, with a flag flying at half-mast for those who they have lost. So heartfelt thanks to all of those of you who served, and particularly all those families who have lost someone important to them. Thank you very, very much. Well, let's see. We've got all our friends joining us here. I've got CNY's Instagram, which is right here. It looks like California. You are number one, my friend. First to join over here, Dr. Bitchcraft. Ooh, I like that name. C. Marie Jaranel Morales. Let's see, Pillarica, it looks like that says. Paige is here. Hey, Paige, thanks for saying hi. Let's see, Hannah Meyer, Faith Waring, it's good to see you as always. No peace in chaos. That is a true statement there. Ariel Eden, hi from California. Glad to have you. Yes, Becca Lopez, you are allowed to ask questions. Please do. Lewis Proverbs 3, I am live, and you're in Denver. Yes, we have an office right here in Colorado Springs. Excited for your consult this Friday. That's No Peace in Chaos. Can't wait to talk to you. Let's see what we got over here. This is my Instagram side here. Oh, yep. And I do see that Bama Gal, who is that very special lady in South Alabama, joined. A hi to Brandis, my cohort, my colleague in arms here. Number one goes out to Angelina Foxy. Thank you for being here today, as always. If you didn't see on my Instagram earlier, I guess it was last week, Angela was here in the office, came back with a very special guest, and that was Nana. And so we did a wonderful little reveal for Nana, showing her what was going on inside the tummy here with the ultrasound. And it was a very, very special day. Angela, thank you for coming all the way to Colorado with your mom, and for being here as always on a Tuesday. From Minnesota, and I always say Wisconsin, but I mean Minnesota. Hey, I'm sorry, I'm just going to wave because I don't know how to say it. A special hello to Amanda, who is joining us in Colorado this week in anticipation of an upcoming retrieval. Hey, Siciliana Melissa. Crystal is with us, and I thought I saw Crystal say that she was on a cruise. Yeah, a cruise in the Bahamas, and couldn't miss the live. Boy, That, my friend, you get a gold star for that. Absolutely. Hi to Elizabeth. Thank you for being here. JM Dots, good to see you as always. A special hello to Zaneta in Miami, who is with us. Lovely Onyx, thank you for being here. Hi, Christina. Meredith Tanoko, the one and only former labor and delivery nurse extraordinaire and a wonderful human being, is also here from South Florida. Meredith, thank you for tuning in. I appreciate that. Let's see, Polar B911 from Vegas. Hey, Sandy, thanks for being here. And let's see, Rainy IVF and Christina. Who do we have? Let's see. So we got a couple of Instagram feeds. We've got YouTube, Facebook, and LinkedIn right here in the middle. And it looks like Jessica is here. Excited to see you guys for transfer again on Saturday. Outstanding, Jessica. I will be working. If a positive pregnancy occurs, when do I stop CoQ10 and L-arginine? You would stop them at the time of your positive pregnancy test. How about that? That was an easy answer. Let's see if we can dive right in and get some questions answered for all you fine folks who are hoping to be pregnant. By the way, I have to say, we've been getting a lot of good positive pregnancy tests, and that is my favorite thing to hear. A lot of times, so in this office, when we can, we will try to reach out to you and call you as a group if we can, but it's just not always possible. So a lot of times folks will get pregnant and I will not hear about it until later on. Somebody will send me a baby picture or an ultrasound picture. And gosh, we love getting those pictures. We love hearing that feedback. So please keep them coming. Send it to us by Instagram. Send us a card. Keep us on your Christmas list. And it looks like, oh gosh, Anna Jet says, I just had my CNY miracle 13 days ago. So congratulations, Anna. Gosh, that is just fabulous. Morellis is asking, does waiting to start stems hurt the egg retrieval? Actually, I'm glad you brought that up. My baseline was last Wednesday, but I won't start stems till 6/1. I'm worried that I will ovulate before retrieval. So this is a very important thing because it seems to be happening more and more. The pace of IVF comes and goes. Sometimes there are a lot of people trying to start IVF at once. Sometimes there's no one trying to start IVF. We may have, 15 people trying to stem start at a location on a given day, and then the next day there might be nobody. But so the way it works here at CNY is that we have a stimulation start schedule. So for each of our locations, for instance, Colorado, Syracuse, Buffalo, Albany, Sarasota, there are a fixed number of people who can start doing a stimulation with their medications on any given day. And that's because we don't want to overwhelm the laboratory. We want to keep it safe both for you and your embryos and your eggs and ultimately to make the embryos at the time of retrieval. So we don't want to overdo it on a retrieval day. So there are a fixed number of stem starts for any given day. If things happen to be a little busier than usual and those stem starts are filled, and I will tell you here in Colorado, it has been that way. Stem starts have been filled and I won't say delayed, but have been pushed back by about a week. So usually what we'll do in that circumstance is that we will start you on some estrogen and progesterone. Some people will use a birth control pill. I prefer to use a little lower dose, some estrogen and progesterone, because that will allow us some luxury of putting the ovaries on pause. We push the pause button, and it basically stops the cycle and allows us to restart it whenever we are 100% ready. Now, I will tell you that most IVF programs in the United States use birth control or estrogen and progesterone to batch their cycles. They want everybody starting in one particular week so that they're going to do all their retrievals in 1 week, or that they're going to do all their transfers in 1 or 2 weeks, and that the rest of the month can be spent doing other things like going on vacation or doing monitoring or whatever else it may be. At CNY, we are doing retrievals every single day. So we don't batch our cycles. Given that important consideration, sometimes things do get the stem start cycle does get filled, and so we will hold off people's cycles for a few days. There's actually some benefits to doing that. It tends to help Morellis to be able to synchronize the growth of the follicles in your ovaries. So that's actually a good thing. And it helps to sensitize your pituitary gland in your brain to the use of these hormones. So I don't mind priming people. And that's basically what we're doing. We're priming you for about, up to 10 days is what I like to do. There are some people who like to prime longer. I used to like to prime longer, but I don't now. 10 days is, 10 to 14 days is really what I would recommend. Sometimes we have to do it a little longer. Maybe you have a cyst in your ovary. We're waiting for it to go away, so we have to prime for 21 days. There's no harm in that. But, when people are being primed for 60 and 90 days, what that can ultimately do is that it can turn down the receptivity of the brain to those hormones. So I personally don't like to do that, but it is not unusual for us to hold off the start of your cycle for 7 to 10, sometimes even 14 days. That happens in all our locations. It is not unique to Colorado or Sarasota. It really just has to do with that stem start schedule. Does that harm anything? No, it doesn't. Now, Morellis, there's a different scenario there if we just said, okay, well, we're going to start your stim on day 10 of your cycle. Well, we wouldn't do that because that's a little too late to start. So we have to put that pause button on the ovaries. And so that's what the estrogen and progesterone is for. And that will stop you from ovulating. It'll stop the ovaries really from doing anything. Literally, it's a pause button. But I'm really glad that that's the first question today, because this has been causing a lot of angst in the CNY system. It's a very common thing to have happen. It doesn't hurt anything. It does not negatively affect your cycle at all. It just helps us to control the logistics a little bit. And on the plus side, it also helps us to synchronize the growth of your follicles. All right. Hopefully that's helpful. Hey, another special little shout out I want to throw around here today, and that is to an extremely special person who goes by the name of Ruby Fink. Ruby Fink, 12 years ago today, was born, and I swear it's like it was yesterday. My dear, this time has gone so fast, and each day that you grow and I get to be a part of it and to see your wonderful and beautiful life and to share that with you is a blessing. To me, you are a blessing. To everyone you are around. And happy birthday, my dear Ruby Fink. Today is that day. So we're having birthday cake tonight. Me and Ruby made a cake last night. And so, hey, Stardust, thank you for the birthday wishes there. We made a birthday cake, and so that was a fun little father-daughter activity. And what it makes me realize is that I hope every one of you get to enjoy those birthdays too. They're just waiting around the corner. Okay, Rosa was told to delay stems until cycle day 11 with estrogen and progesterone. We'll worry that will compromise egg quality. No, that will not compromise egg quality. It may actually improve egg quality. So basically, you're going to be on estrogen and progesterone until what you think is your cycle day 11. But when you stop that estrogen and progesterone, that's actually resetting you. That is your new cycle day 1. So that's actually helping your ovaries. That estrogen and progesterone creates new estrogen and progesterone are the language that the ovaries speak. And so it is creating new blood supply. It's helping carrying some of the nutrients to the ovaries. It's synchronizing the growth of follicles. So, Rosa, not a problem there at all. What would be, this comes from Becca Lopez, the process like for someone who has lost a baby? Well, pregnancy loss is a terrible thing that we wish no one had to go through. There are, and this is it's a hard thing to talk about, but I'm glad you brought it up, Becca, because these are important things to answer. We treat these things differently depending on when that pregnancy loss took place. If it was a late pregnancy loss, let's say what we call a fetal demise, oh, heaven forbid, in the third trimester, well, how we get you pregnant doesn't change really very much. For folks who have had recurrent pregnancy loss in the beginning, let's say in the first trimester of pregnancy, there are some different things that we would do that go along with our immune protocols. Um, we would use some Prograf, which is now used to help prevent uh, autoimmune rejection of a pregnancy. We would use typically some Lovenox, which is a blood thinner to stop blood clots from occurring in the small vessels that supply the pregnancy. So really, it sort of depends on when that happened, Becca, but it is something that we are unfortunately all too used to having to address, and we'll be happy to talk about it with you. Hi, Kayla Baker. Any advice for autoimmune patients? Well, pretty much everybody at CNY gets some version of an autoimmune protocol. And that is some different medications, different interventions that we use in order to try to suppress your body's immune response against pregnancy. We know that the immune system affects the way some of us are able to get pregnant or stay pregnant. And so we have four different immune protocols. Typically, we approach each patient individually, but it's either usually level 2 or level 3 immune protocol. If you have a known underlying autoimmune disease, we typically go with the level 3. What is that? Well, that's a dose of some prednisone. That's the use of our antihistamine protocol, which is Benadryl, Claritin, and Pepcid. That is some low dose naltrexone, which increases your endorphins, which has a positive effect on your immune system. Um, Let's see what else. That's the Prograf medication, tacrolimus, which I spoke about before. Sometimes we use a medication known as Neupogen. We can use the Lovenox, the blood thinner, a baby aspirin. We use an infusion of a medication known as intralipid. Intralipid is like getting an IV dose of the keto diet. So it's a natural infusion of fat that is very strongly anti-inflammatory, and also seeks to it targets really specifically what are known as natural killer cells, which are a hard thing to effectively test. So we do recommend folks treat for that without having to test, because the testing is fraught with error. And let's see, sometimes there's an HCG wash. We can do a PRP wash of the uterus, a Neupogen wash. Really depends on individual scenarios. But usually, if you have a history of autoimmune disease, we usually step up that immune protocol just to make sure that we are not letting an immune response get in the way. Let's see. No Peace in Chaos says, when would mini IVF be recommended? So, mini IVF means that we're using a low dose therapy. And really, honestly, you can do a mini dose in just about any scenario. When we dose medications for IVF, we're usually selecting those medications based, number one, on your age, and number two, on your AMH, the anti-Mullerian hormone, or the ovarian reserve level. Well, the old thinking was that, well, if you have a diminished ovarian reserve, or if you're a little older and it's going to be harder to get your ovaries to respond, then we would want to pour as much medication on your ovary as we could in order to try to get you to respond to that medication. Well, what we know now is that higher doses are not better. You start to get diminishing returns with higher doses of medication. So, stimulation for IVF, we want to find a sweet spot. We don't want to go too far, but we want to give you enough. What the data shows us is that instead of a very high dose therapy, using a mini dose therapy gives us the same outcomes as we might get with those higher doses, but at a lower exposure to medication and thus a lower cost and a lower side effect profile. So a mini dose can be used really, again, in any scenario, but in some cases, using a mini dose may be too low a dose for you and may not optimize your outcomes. I think of the best time to use what we call a mini dose therapy is when we might classically have used a very high dose therapy. So mini dose is replacing a very high dose and can be very effective. Christina is asking, if you have endometriosis, do you think that the HCG wash is a good idea? I've heard that people sometimes get fluid buildup, which is bad for transfer. What do you think? An HCG wash uses a little bit of fluid of the HCG hormone in order to bathe the lining of the uterus. What this does is that it turns up some of the pregnancy receptors and makes that endometrium, the lining of the uterus, theoretically more receptive to the pregnancy. That's a good thing. You are correct that if you have too much volume in that HCG, then you leave a bunch of fluid left inside, and that we don't like. So we don't want to do an embryo transfer if your uterine lining is full of fluid. It is a very, very rare occasion that I see folks do the HCG wash appropriately, which is in the day or two before the transfer, where there is still HCG or liquid inside the uterine cavity. Now, there is a lot of talk, people have a lot of talk about the what they call the microdose HCG wash, which is done at the time or on the day of your embryo transfer. I do not recommend that. Many people, there's a small study that's out. A lot of people have read that study and think that, oh, well, that must mean it's a very good thing. That's what I want. We have found that actually decreases outcomes. And so I 100% do not recommend doing the microdose HCG wash on the day of transfer. Why might it lower those outcomes? Well, I think it may have to do with the amount of fluid that's present. The small study that looked at it said, "Oh, it increases outcomes," but our own data at CNY says it does not. So I don't recommend it. But Christina, I think it's okay for sure to do a wash of the uterine lining. We want to do it the day or two before, and you are absolutely right. That is the reason why. Hi to Carrie. Let's see, just had my CNY baby last Thursday. Congratulations. Ken, boy, I'm having a hard time saying it. Kenny Deal Latham. I think that's what that says. Congratulations. I had a postpartum hemorrhage. Is there a correlation of IVF and postpartum hemorrhaging? Not explicitly. However, folks who have experienced difficulties with fertility may have an increase in certain pregnancy-related risks. And there are some IVF-related pregnancy risks, specifically if you have done a medicated cycle for embryo transfer. It does increase the risk of hypertensive disorders in pregnancies, and that can sometimes also be associated with postpartum hemorrhage. But in general, IVF, is a safe thing to do, and postpartum hemorrhage is also associated with an abnormal placenta, an abnormal type of placentation, and that is something that can happen frequently in the infertility population, which includes those folks who have done IVF. So glad everything is okay and hope your baby is at home. Congratulations. Hey to Elizabeth. I've had 3 failed to implant donor embryo banked eggs. I am prepping for a 4th transfer. I had embryos frozen after retrieval. Do you think I should rely on the results of the EMA and ERA test? Well, I am not a believer in the ERA test anymore. The EMA and the ALICE test is a way of of being able to test what's known as the uterine microbiome. I think that there are less expensive ways to do that. Um, and the ERA, which stands for an endometrial receptivity assay, is something that we used to recommend all the time. It was part of our armamentarium for folks who have had recurrent implantation failures. Well, the studies now show us that it doesn't really matter what your results are from the ERA, that the pregnancy outcomes are not affected, whether you're what's known as pre-receptive or receptive or post-receptive. That at the end of the day, looking at thousands and thousands of cycles, there's really not a difference in the pregnancy outcomes, no matter what you kind of score on your ERA test. So I really don't recommend that test anymore. However, there is a test known as Receptiva, which looks for silent endometriosis. And I would very strongly recommend folks consider doing that test, especially if you've had a history of should have been implanting and not. And then the other thing, Elizabeth, in your situation, 100% is the use of the Prograf medication for recurrent implantation failure. Has a very dramatic effect on improving pregnancy outcomes, not only on getting positive pregnancy tests and ongoing pregnancies, but decreasing miscarriage rates and also decreasing some bad pregnancy kinds of complications that can happen. So 100% there. Yep. Hi, Rainy IVF. Just wanted to say, oh, welcome, baby Matilda. Thanks to your care and a September FET. That is such happy news. Oh, God, we love that. That is the best. Awesome. Okay, let's see. Let's head over towards the Facebook side. Megan is here. Just found out I'm having a baby boy. Awesome, Megan. That's fantastic. 13 weeks after my first transfer in Buffalo. That is amazing. Thank you, Megan, for sharing. Heidi is here with us. How many infusions does someone usually do? I think, well, we talked about lipids, so I think you're asking about the lipid therapy. Well, you can do lipid therapy on a weekly basis through the first trimester or even through 14 weeks. Most people do one. Most people do the one that is right before transfer. I think that is the most important one in the general population. If we know that there is some other issue, then there may be a more compelling reason to kind of keep doing those transfers, or rather to keep doing those infusions. But certainly, I think the one before transfer is the most important. And the other thing, it's hard to find places where you live, oftentimes that are able to do those infusions for you. So logistically, it may not work out, but certainly at least that one. Heidi, looks like Kelsha is here. Dr. Fink, why do you guys transfer or freeze on day 3 instead of a blast on day 5? Well, you have an option. You can do either a day 3 or a day 5 freeze or transfer. Why would you do one or the other? CNY has a typical protocol we recommend, and that is that if there are 5 or more embryos, we recommend that you grow them to blast. When you grow an embryo to the blastocyst stage, the blastocyst we know has a higher probability of being able to get you pregnant because it has survived past the point of just trying to divide and has become a little functioning machine. And that's a good thing. But if we are limited in the number of embryos, let's say you have 3 embryos, our feeling is, well, yeah, you can try to grow them to blast in the lab if you wish. And that is ultimately 100% your choice. But the risk is, well, what if they don't grow? What if they die off in the lab? And that's a possibility. Whereas if that embryo went inside of you, it may have the opportunity to grow. It may live inside of you, whereas it died in the lab. So if we're limited in the number of embryos, all day long, I would much rather see an embryo going inside of you than an embryo dying in the lab. So that's the rationale between day 3 versus day 5. There is nothing wrong with a day 3 embryo. We just can't predict as well, will it continue to grow? How healthy is that embryo? We can look at them and say, well, they look good, but does that mean anything to predict success? No, it really doesn't. So our protocol typically there, Kelsha, is based on how many embryos you have, and that's what gives us our recommendation about when you should either freeze or transfer. It looks like Nincy is here with us. With my low dose mini IVF, I ended up with 5 embryos. So happy, can't wait to transfer them. Don't transfer them all at once. Just kidding. We wouldn't do that, but 5 embryos to transfer is probably not the best idea to do at one time. However, there are situations where it might be. If you're 45 years old, you can transfer 5 embryos. That's part of the whole guidelines that come from the American Society for Reproductive Medicine. And it is a very common question: how many embryos should I transfer? If you want to look at those guidelines, ASRM, American Society for Reproductive Medicine Embryo Transfer Guidelines. That's all you have to Google or ask one of us. We're happy to go over it with you. Hi, Emmy. Is there an upper age limit for ovarian stimulation? Would you still try to harvest eggs in someone who's 49 years old? Or do you think donor egg is best? Well, so at 49 years old, the odds of being able to get an egg are very low. The odds that the egg we might be able to get will be normal are even lower than that. And the odds of that egg fertilizing and creating an embryo that will result in a live birth are sadly infinitesimally small. Now, that doesn't mean that the odds are zero, but they're pretty near zero. So, would it be better to use a donor egg? Well, to use your own egg at 49 is an incredibly hard uphill battle that may not result in the outcomes that we wish. Whereas using a donor egg is a situation where we can probably have you pregnant in 2 or 3 months, pretty quickly. The donor eggs come from very young, healthy donors with stable DNA in their eggs. They're all proven to have had kids. And so the odds of you being able to conceive with an embryo derived from a donor egg the odds are extremely high. Whereas at 49, using your own eggs, unfortunately, the odds are extremely low. What some people opt to do, and this is 100% a reasonable choice, is to say, well, I'd still like to try it on my own. And that would be maybe what we call a closure cycle, to convince yourself or to just, see what's going to happen. You do your own stimulation and you do a donor egg backup. In the case of the donor egg backup, you purchase a cohort of eggs that can be fertilized at the same time your own eggs are fertilized after your retrieval. And that way, one way or the other, you're going to leave that cycle with some embryos that have a reasonable probability of being able to get you pregnant. It may be yours, they may be the donors, or there may be some combination of. So that's called a donor egg backup, and I think it's definitely a good idea. If you're 49, just recognize I don't like to discourage anyone. I think life is too short to be pessimistic, but I want people to be realistic. Not an easy climb. But certainly one we're willing to make with you. Now, I will tell you that most IVF programs would not do IVF on you at 49 because they want to be able to report their outcomes. They want to artificially elevate their outcomes and say that they, have this astonishingly high pregnancy rate because they're sort of cherry picking the patients that they're doing their IVF with. Their ideal patient is someone who is 25, already has 3 kids, had a tubal ligation, now has a new partner and wants to have another baby. That's their ideal IVF patient because the odds are very, very high that she's going to get pregnant. So hopefully that's happy there. Any suggestions on supplements for male sperm for fresh sperm sample waiting on our egg donors cycle. I believe there's a wonderful molecular fertility male fertility supplement, and you can find that at molecularfertility.com. Chris Ann says, my baby is 3 years old. Can't wait to transfer soonish again at Colorado Springs. That is awesome. My baby was a successful fresh transfer. This one will be frozen. My biggest fear is losing an embryo during the thaw. Do you see a day 6 blast not making the thaw very often? Is it a legitimate fear? Well, Chris Ann, that is definitely a legitimate fear. Of course it is, because you never know what can happen. However, the success rate from thawing embryos is about 97%, which means that 3 out of 100 embryos will not survive the thaw. That's a really good number. And in fact, that may even be conservative. It may be a better or a higher success rate even than that. But that's industry-wide, that's the number that we quote. The process of freezing an embryo is what's known as vitrification. And that has changed. The way that we freeze embryos has changed over the years. Our embryologists have gotten better and better at it. And so now they really know how to do it, because, even one little ice crystal inside that embryo can damage the embryo and make it not survive. So they do it pretty well. 97%, I think, is a great number. And I will tell you also that the success rate from, you had a successful fresh transfer that resulted in you having a baby. Well, the success rate from frozen embryo transfer is significantly higher than that for a fresh transfer. So I think you have a lot of things to look forward to. So best of luck there, my friend. All right. Hi, Leah. Good to see you this afternoon here too. JM Dot says, is there a concern with the following hormone levels in the context of a cycle for a 46-year-old after coming off 2 months of Orilissa? Estradiol 63, progesterone 0.2, LH 26, FSH of 35. Yes. So if your FSH is 35, that tells me you're still that number is a little bit high. So I'm not sure if you're planning to do an embryo transfer there, JM, then that's okay, because if we're doing a medicated cycle, we're going to give you all that estrogen and progesterone, and so we don't have to worry too much about where your own numbers are, because you could be very far menopausal. We're going to control all of those hormones, and so we're going to control the way your body responds to it. So I would say that if you're doing an embryo transfer, as long as that's a medicated cycle, I think you'll be okay. So, says Polar B911, with a donor egg, can I please transfer 2? They are untested but of good quality. What are my chances? Well, if you are using a donor egg, an embryo that's derived from a donor egg, the ASRM guidelines are that you would transfer 1, because we want you to have 1 healthy baby at a time. Putting 2 in does not, especially on the first transfer, does not necessarily improve your live birth rate. It may increase the risks or the chance of a positive pregnancy test, but unfortunately increases the risk for pregnancy loss. So therefore, the recommendation is that you would transfer 1. If it is not your first transfer, in some circumstances, the guidelines can say, well, maybe you can transfer more than 1. Now at CNY, we will not turn you down if you want to transfer 2. We don't technically give you permission to say, oh, hey, yes, you can do this outside of guidelines. That's ultimately your choice. It's our job to educate you on that. There's a consent form that you would sign, and then generally speaking, we would do it. Now, there are some caveats to that. I've had some folks who come in and say, well, my last, I had twins. I had preterm labor at 17 weeks or at 22 weeks and delivered, and unfortunately neither of them made it, and I want to put in 3 embryos now. And I will say, no, that's a bad idea, because you've already proven that your body didn't like having the twins, and bad things happen. So we don't want you to have a repeat performance. We want you to have a healthy baby. So but in general, they're Polar Bear or Polar B 911. We won't tell you that no, you can't. Leah Schmink says, does prednisone have a benefit during egg retrieval if you know you are doing a frozen transfer? That is a controversial question. I don't mind. So there are some studies that look at using um, um, uh, cortisol-related steroids in an stimulation cycle to improve outcomes and to sensitize the ovaries. So that's the most common reason it is done, and generally speaking, it is done kind of across the board at CNY. Do you have to do it? No, you do not. Does every practice do it? No, they do not. Some people don't do well with prednisone. They don't feel well. They don't like it for one reason or another. And in most cases, Leah, if you were to say, you know what, I don't want to do it, I would say, not a problem, not a problem at all. Lovely Onyx says lower pelvic pain in early pregnancy when I move or pee. Small subchorionic hemorrhage seen on ultrasound. What can I do to help? So there's not a lot you can do for a subchorionic hemorrhage except to let it heal up on its own. Now, let's talk about this pelvic pain that folks have early on in pregnancy. And for this, I will, of course, consult my handy uterus, who will say, hello, hello, hello. So the uterus sits, okay, so we have to have a visual here. And my anatomy is not appropriate, but nevertheless, uterus sits right down here. Would you agree? And the uterus is connected by some ligaments that run here and here. These ligaments, if we looked at them and if we cut them, they're round. And they're called, coincidentally, the round ligaments. The round ligaments go into a space on the inside of the pelvis and actually run down into the vulva, ligament-wise, into the labia majora. So as the uterus grows, these ligaments will pull. And when they do that, it often causes some discomfort. If you're early on in pregnancy there, then it may not be round ligament pain, but it is something that we commonly start to see in the mid-second trimester, and certainly on through the early second trimester and through the middle part of that. And that's because the uterus is growing. These ligaments are pulling. It can be a crampy sensation, or it can be a sharp pain. Sometimes that pain feels like somebody is sticking you with a knife. I've had people who think they are certain that they have appendicitis because that pain can be so sharp. It is positional. It is usually if you lie down or you roll over or you move one way or the other, the pain either typically gets better or worse. That's usually round ligament pain. And again, it is over here on the sides of the uterus and runs down into the vulva. Sometimes you get a sensation of a pulling kind of in the labia, and that's very common. The other thing that's happening there early on in the pregnancy, is that the uterus is really trying to grow. It's getting a huge amount of your blood supply, and it's trying to grow. And so do you feel that? Hell yeah, I think you feel that. You feel that uterus growing, and as it grows, it's pulling the placenta along with it. And as that placenta pulls, it can create a little space underneath the placenta that fills with blood. And that is what a subchorionic hemorrhage is. It is literally a bruise under the placenta. It is very, very commonly seen in pregnancy. In fact, 1 out of every 2 pregnancies will have some cramping and bleeding in the first trimester, and that subchorionic hemorrhage is the most common reason why. In most cases, it just goes away. So like any other bruise, it just gets reabsorbed into the system. But sometimes a little bit of that blood escapes out the door down towards the cervix, and that's where the bleeding comes from. Not a lot you can do about it except to really let it heal. By the way, if it turns out that the round ligament pain is becoming uncomfortable, there is a gadget that when I was practicing obstetrics was a real lifesaver for a lot of people. Some people would just use a belly band, but there's an item that's called a prenatal cradle. And there are different varieties of them. There's one you can sort of strap around your back and over the breasts, and it kind of goes down here and it lifts up on the uterus and supports those round ligaments, which is really a very, very nice thing. So that's called a prenatal cradle and is really very helpful for that round ligament pain. Hey to Nikki Jones, good to see you. Shabnam, thanks for being here today. Are there any potential issues with someone who's been diagnosed at a young age with a pituitary adenoma? So we want your prolactin hormone to be normal. People who have a little growth or what's known as a microadenoma in the pituitary gland typically are making too much prolactin hormone. The prolactin hormone is what, like it sounds like, it causes lactation. It causes the breast to leak. Um, it can also, as that hormone goes up, it can interfere with both thyroid and with the hormones that cause estrogen, progesterone, and ovulation. So we want that hormone level to be normal, in the normal range. There's a medication we use for that. It's called Dostanex, usually twice a week. Let's see what else we got going on here. Oh, you know what? I skipped over here the CNY side. Let's see. Molly Maroney says, I am panicking. Don't panic, Molly. Supposed to have cycle day one this Friday and plan to drive up from Texas to monitor with you guys the entire time. Are y'all pausing a lot of cycles of people monitoring with you locally? There's generally some kind of workaround. So if, just tell us kind of what's going on with you, Molly, there. If the stem start schedule is full, then really it's kind of a safety issue, but it shouldn't be a deal of more than really just a few days. So don't worry too much there. Hey to Heather Lynn, nice to see you today. Let's see. Hi from Michigan. Oh, Heather's in Michigan. Starting our IVF journey in July. I'm so overwhelmed and scared. That comes from Paige. It's a big thing it's a big bite to take, out of the apple. It really is. But fortunately, I have to say this community is so wonderful. There are so many opportunities to, get questions answered and to be kind of mentored, if you will, by really loving people who have been through this process. We do this enough that it shouldn't be scary, anymore. It is because there's a lot of unknown. It involves a lot of medications and a lot of hormones that, you may not have really thought about too much anymore. There's always a worry about, is it going to hurt? Is it going to be embarrassing? Who's going to be looking at me? And then, of course, am I going to get pregnant with this? And then what's going to happen day to day in my pregnancy? What's going to happen in my relationship? Am I going to have a child? Is that child going to want to go to college? Is that child going to get a job or get, in trouble with the cops? Or, who knows? The worries never actually go away, Paige. But as far as this part goes, I want you to feel like you are so supported here with this group of people. I have to tell you, this is my favorite place to be all week long, because the names that I see here, the questions I see, and really the love and care that comes from this group of people is so exceptional. So thank you all. God bless you all for being here, not just for me, but really for each other. It's really truly, truly a wonderful thing. Let's see. Rosa says 41 years old, AMH of less than 0.3 and endometriosis. If I take Orilissa to suppress before an embryo transfer, will my ovaries wake up with the low AMH to do a modified natural? Most of the time they do. If they don't, not a big deal. We can always just convert it over to a medicated cycle. I would not try to do a totally natural cycle FET after doing suppression for endometriosis, because we have pulled the plug on the hormones. It may take a little bit in order to get the brain to kind of wake up, the pituitary to wake up and to start making these hormones normally again. But in a medicated cycle, what we're doing is we're giving you the ovulation induction. So we're making sure that the ovary is going to wake up. So most of the time it does work out okay, Rosa. So, but worst case scenario, if you take that medication and your ovaries are still like Silence of the Lambs, then we can just give you some estrogen and progesterone and still absolutely give you the same kinds of outcomes with your embryo transfer. All right. What else we got? Can I do an egg retrieval with letrozole only and a trigger? I make a low number of eggs. Yes, you can. Yes, you can. People can do IVF with just oral stimulation. Typically, with oral stimulation, you may get 1 to 2 eggs. And unfortunately, the cost of IVF is the same whether you are going to produce 1 or 2 egg follicles or if you have 25. So using stimulation sometimes will give you more follicles. But if you've tried that and you really don't make them, absolutely, you can do it much less expensively with, say, for instance, letrozole alone. Would you recommend doing a medicated transfer after a hysteroscopy? The OB/GYN removed a lot of lining. She said the lining would be very thin. I was planning to do a modified natural. So if this comes from Ariel Eden, if they have removed a lot of the lining, I would really want you to wait for at least a cycle and see how that lining grows back. In theory, it should grow back and do just fine, and then a modified natural cycle is fine. If, let's say, gosh, you never really get much of a period after that, well, then we may have an issue. And in some circumstances, it might be better in that scenario to do a medicated cycle. But I would say I'd want you to wait, see what happens with your period. Assuming that you get periods again, I'd say it's no problem to do a modified natural. Hey, it's 10 minutes till the top of the hour, and you're on Fertility with Fink and Friends. I'm Dr. Randy Fink in Colorado Springs. Let's see if we can't spend the next 10 minutes on all your questions here. Going back over to the Facebook side. Let's see, can birth control or Plan B affect your AMH taken a month before the blood test? So birth control can definitely lower your AMH. Absolutely. This comes from Britt. Birth control can lower the AMH. It is said that it can lower the AMH by about 30%. I've actually seen it lower the AMH very significantly more than that, so it can. I don't know about Plan B as a single dose medication, whether that really would, but birth control certainly can. Ninzi says, we just freeze our embryos at day 3. I'm 29. I was wondering if my first FET fails, can I ask for 2 embryos to be transferred on the second, or is that impossible to do because of my age? Nothing is impossible, my friend. Nothing is impossible. Yes, you can. Yes, you can. KK says, I'm not sure what she's talking about. I've been taking that for 6 months. So, I see. Going back up there, it looks like from I missed a couple of questions here. Sorry about that. Britt also says, speaking of thawing and freezing embryos, is it possible to do a retrieval in Colorado and freeze the embryos and ship them to do the PGT testing at CNY for gender and only ship back the gender preferred embryos? Okay, so it doesn't quite work that way. So the eggs are retrieved. Eggs are retrieved. Sperm fertilizes the egg. That creates an embryo. The embryos are grown, and then when they reach the blastocyst stage, they are biopsied. It is the biopsy, those few cells, that is sent to the genetics lab, and the genetics lab we use is called Cooper Genomics. The biopsy is sent to Cooper Genomics. The embryos are frozen and stay here. They don't travel. The embryos stay put. Now, could you transfer those embryos, ship them someplace else? You can ship them any place you want. Yep, you can take them to a different facility if you wanted. You could take them to another CNY location if you wanted. But basically what happens after, 10 or 14 days or so, the PGT result comes back, and then you get a phone call from both get both a phone call and a written report. The phone call comes from the embryologist who will go over those results with you. And then based on that, you can decide which embryo you want to transfer, but to, transfer to you. Embryos don't have to get shipped anyplace unless you want to send them away. So hopefully that is a little bit of a clarification there. Kelsha says, using a donor, egg donor since they are younger, Do they have more mature eggs that will grow to blast, or do I need to have more than 6 eggs that the package offers? In most cases, I would think that you will, your odds are high with a donor egg of getting an embryo that is going to get you pregnant. So whether you grow it to blast or whether you transfer it at day 3, either way, it has a good probability of sticking. So, we can talk about individual scenarios there, but since it has a good probability of sticking, hopefully you will have a good result with that first cohort of eggs. KK says, I'm wanting to try IVF soon. I'm from Oklahoma and I've been trying for 10 years. My tubes are blocked. What steps do I take to start IVF? You pick up the phone and you call us and schedule a consult. So there are some blood tests. There are some things that we'll want to do ahead of time, but you have a consult with us. That process is usually the slowest part of it, is kind of getting over that fence. We are the lowest cost IVF in the country, and so there is a demand for the service. So it may take a few months to actually get that visit. It's a telemedicine visit. It's done remotely over the phone. We order the blood tests for you, the hormone levels based on what we see. We develop a protocol and then help you figure out where you can do your monitoring for IVF, which you can do right at home there in Oklahoma, and just come to us for your egg retrieval and for your transfer. So the process is hopefully made pretty easy. CoQ10 is amazing for egg quality. This is Chris Ann's comment. Definitely check out the supplements and ask what you can do to better your egg quality. Yes, CoQ10 is probably the most important of the supplements for egg quality. And that would be 400 milligrams of the ubiquinol form or 600 milligrams of the ubiquinone form. All right, let's see what else we got here. Samantha says, thoughts on transferring a low-level mosaic. We have 2 euploid girls, but would love to use our low-level mosaic if we can. So that, it looks like, is a minus 13 chromosome. So mosaic embryos may actually be normal embryos. The ones that I am very hesitant to transfer are the ones that are involve chromosome 21, because that's where we're dealing with Down syndrome and trisomy 18. If it's a 13 issue, hopefully what that means is worst case scenario, it just doesn't implant. A mosaic embryo is still a good embryo. We know that with a euploid embryo, you've got a 65% probability of pregnancy. 65%. That's pretty dang good. Depending on how old you are, if we have an untested blast, it's anywhere from low probability, less than 5%, all the way up to 40% if you are, let's say, under the age of 35. Well, a mosaic embryo, instead of that 30 to 40% number or the 65% number, falls in at about 45%. So there is a little higher risk for miscarriage with that embryo, but please don't think that you have to destroy your mosaic embryos, because they absolutely can give you a baby. What happens if you have your egg retrieval and you get no eggs? Well, it can happen. Usually in most cases, we would see that coming, like you're not really developing many follicles. And so if you haven't developed any follicles, we may say, hey, do you really want to go through this? Because it looks like there's not going to be a lot to retrieve. Now, sometimes people surprise us and they have all kinds of follicles and we end up getting no eggs. And these are unusual scenarios. That is not the norm. And that comes from Life with Emberlane. I like that name too. Natalie Foster says, what are your thoughts on HCG wash? Wondering if I should consider it. Yeah, we talked about that a little bit before. I do think an HCG wash is a good idea, especially if you've had an implantation failure before. It increases the odds of implantation. JJ family story. Known endo, last laparoscopy was about 1.5 years ago. Would you recommend another laparoscopy or suppression before transfer? I would recommend suppression. Unless you have, I don't recommend laparoscopy strictly for fertility purposes. And that goes along with the guidelines from the ASRM. And where does that come from? Well, it's data based. And that is that, if you've got severe pelvic pain, if you've got, a pain syndrome associated with your endometriosis, and you're back in pain again, you may do better by having a laparoscopy because we can do some things to fix the pain. 2 months, 60 days of endometriosis suppression, which is what we recommend for endometriosis, is not likely to have a big effect on the overall course of your symptomatic endometriosis. What it does do is have an effect on your endometrium and improve the odds of an embryo transfer. So, JJ, I think it depends on really how you're feeling. And if it's just about trying to get pregnant, I would say you can empirically do some suppression. I think that's a much better idea than having to have another surgery. Lily Rios says my AMH went from 0.44 to 0.87. Is this normal? I'm 43 years old. Well, there can be some fluctuation in that AMH number. So I would generally, err on the side of, in my own mind, thinking of it as the more conservative number that we want to intervene with you based on as though it were the lowest number that we know it was. So, and in the case of 0.4, 0.45, 0.44, 0.87, we're probably going to treat you really about the same. But yes, you can see some fluctuation in that number, and that's generally normal. Thanks for the birthday wishes to Ruby there, Jay. I appreciate that. And Lily, thanks. You too. Jay DeRoe says after multiple failed donor egg transfers, and over 40, can I transfer 2? I think we answered that. I think we did. And I would for sure be using Prograph. Absolutely. Your favorite AVP says, 42 in July, first IVF, 3-day fresh, no implantation. Did an IUI, got pregnant, but miscarried at 6 weeks. Should I PGT test for the next IVF cycle? Well, so that miscarriage was unfortunately probably related to something that's chromosomal. I consider the best use of PGT to be to take a large group of embryos and to help to select out those that have the greatest probability of getting you pregnant. So would I use it to test, 1 or 2 embryos? No, not so much. If you're going to do several cycles, you can, kind of bank them up and then do testing. And then we know that which ones are more likely to get you pregnant. And of course, it's a 65% probability of pregnancy with that. But if you have limited numbers, I don't generally recommend PGT because your body is going to give you that same information. You put the embryo in, it's either going to stick because it's normal or it's not because it's not. It is 2 minutes after the top of the hour, and we have gone on. I hope they don't shut me down here. I want to say, gosh, it's always so good to be with you folks every Tuesday at 4 o'clock p.m. Mountain Time and 6 o'clock on the East Coast. That means 3 in the West and 5 in the mid-range. Fertility with Fink and Friends is my favorite place to be all week long, and I really appreciate every single one of you being here. The world is not a kind enough place, and so the sign behind me there, which comes from my dear friend Jody, who is now the embryologist in Sarasota, lead with kindness. Kindness every step, love, and remember there is always hope for tomorrow. Tomorrow is a new day. The sun rises and it brings us all new things. This whole infertility business is not the story of your life. It is merely a chapter. And what are we here to do? We are here to rewrite it. And let's do that together, shall we? Thanks so much for being here. I'll see you next week. Till then, good night.